Cardiology Update listeners and viewers. Thank you for joining us today. My name is Shadi Reyes. I'm an interventional cardiologist at Detroit Medical Center in Detroit, Michigan, USA. Today, I'm really coming to you with a podcast related to a very interesting, recently published article at the JACC journal. The article touching a very important topic related to outside hospital cardiac arrest and the triage or the need for coronary angiogram. This is a very important topic and has been discussed in multiple venues and still till this date is very challenging. For example, all of us get activation for a STEMI for somebody who arrested outside the hospital. But the struggle comes between when we speak to the emergency department, whether this patient need to come to the cath lab for coronary angiogram or not. So this article kind of shed more light on and kind of give us more guidance on how we treat these patients and how we triage them when they come to the emergency room. So again, this trial was done, or study is a retrospective study. They looked into all the outside hospital cardiac arrest in Switzerland from 2011 onward for 8 years. More than 300 patients were included in this analysis, and the findings are very interesting. These patients are never had any ST elevation because we know a patient who have ST elevation, myocardial infarction, and cardiac arrest need to come to the cath lab. But these patients did not have that on EKG. So they triage the patient based on stability or unstable. Basically, if the patient has low blood pressure or somebody has VF or VT compared to somebody who is more stable. And they look to see how these patients were treated. So almost 43% of the patient had cardiac arrest outside the hospital, and they were hemodynamically stable, and the rest were unstable. It's very interesting to find that the impact of instability or stability, meaning if somebody blood pressure low or high or normal, did not differ in terms of outcome. But what really differs if somebody had VT, VF, or if they had ST changes, or if they had before the patient comes to the cath lab. And the outcome of these both cohort of patients who came to the cath lab and eventually went for angiogram, they were the same. But the patient who went for the cath lab has a lower cardiac death, but the all-cause mortality or all-cause of death was the same. So how this article will impact the practice that we have now? The guideline currently from the American Heart Association and the European Society of Cardiology still recommend bringing patients to the cath lab who are having outside hospital cardiac arrest, who has VT, VF, and ST elevation, because this is most likely an ischemia-driven cardiac arrest. But the others who doesn't have that ST changes or doesn't have this VT or VF, usually the recommendation, not with no trials, but just the recommendation is maybe these patients should be different from coming to the cath lab. Now, what this article is really imply is that these patients who have stable, hemodynamically stable, and also have VT or VF and come to the cath lab, the chance of having occluded artery is pretty good. And maybe that will impact the outcome and impact the cardiac death outcome in this cohort of patients. So one thing is I would like to also highlight is the fact that all-cause mortality, the causes of all death in both groups was the same. So we're going to ask, so if the all-cause mortality is the same. As we know, these patients are sick and usually coming intubated. We don't know how long the CPR duration was. Is it 20 minutes, 30 minutes, 45 minutes? And also the most important question is if this arrest was witnessed or not witnessed. Although this data is, you can find it in the detail in the paper, but it still does not kind of impact the outcome of these patients, or it wasn't studied enough to look into if this downtime affected the outcome. So in general, just to remind everybody with the current guidelines from the American Heart Association and American College of Cardiology, the guidelines now, if somebody has a cardiac arrest or CPR more than half an hour, if the pH less than 7, or if the patient has above, have been lactate is elevated in double digits, maybe this patient, the chances of coming to the cath lab and surviving is pretty low. So again, this study is helping us for the patient who are hemodynamically stable, no ST changes, if they have VT-VF, as well as if they have an evidence for chest pain before coming, then it's good to bring them to the cath lab. It's recommended to bring them to the cath lab because the chances of having occluded artery is 50%. I hope you find this podcast useful. Thank you so much for joining us. Till next month, this is Shadi Reyes from Cardiology Update.